Hello, everyone, and welcome to the Patient Health Alliance NMOSD Master Class. We welcome all attendees and remind that the Patient Health Alliance is a source of information and education for NMOSD and related conditions. The content of the following presentation is based entirely on published data or expert opinion. PHA is not a clinical provider and does not offer diagnostic, therapeutic, or clinical care recommendations or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. The NMOSD Master Class has several overarching goals. First, it's intended to be a practical update of latest information on specific topics. Second, it's intended to illustrate key themes or clinical pearls. It's also formatted to be inclusive of non-specialist audiences. And lastly, it contains an active question and answer discussion time to emphasize key points. My name is Michael Yeaman, and I'm happy to be the moderator today as an advisor for the Patient Health Alliance. We are delighted to welcome Dr. Ben Greenberg of the University of Texas Southwestern. Dr. Greenberg is Vice Chair for Clinical and Translational Research in the Department of Neurology at UT Southwestern. The topic today, Adjudicating Relapses, Why and How. With that, Dr. Greenberg, thank you so much for being here, and we look forward to your presentation.
Thank you for having me today. I'm very excited to be joining this group discussing this topic, adjudicating NMO relapses, why and how. And on its face, this may seem like an academic question. How do you decide when a patient is having an acute inflammatory event related to neuromyelitis optica? But in the end, this becomes critically important to the practice of care and science in the world of neuromyelitis optica. And when thinking about relapses and the why and how of adjudication, I want to start by recognizing there's two sides to this topic that each has its own implications. On one hand, we can talk about adjudicating relapses relative to clinical trials and what has been done in the past and what are the implications of the decisions that are made during clinical research endeavors. Ultimately, it is the adjudication of relapses that help us decide whether or not an intervention has been successful at preventing new disease activity. So the definition and process for relapse adjudication is critically important. But independent of this, and quite unique from the clinical trial experience, is the adjudication of relapses in my clinic, the clinical care of patients, and deciding when and how an individual's symptoms rises to the level of a confirmed relapse, and what are the implications of that decision. So I'd like to talk about each of these topics in turn, and I'm going to start by focusing on clinical trials, because usually when we use the term adjudicating relapses, most of us think about clinical trials, particularly around that term adjudication. The notice of a process or a committee of individuals coming together, looking at data, and deciding whether or not an event rises to the level of being characterized as a relapse. And so in the context of clinical trials, I thought we would use the history we have over the last decade of randomized controlled trials and how data was analyzed to determine whether or not an individual had suffered a relapse. So the trials I'm referring to are ones that I'm sure we're all familiar with. Both the PREVENT and CHAMPION NMOSD trials, which looked at eculizumab and ravulizumab respectively, relative to the treatment of neuromyelitis optica, the N-MOMENTUM trial, which was a study of inebilizumab, and then two trials, the SAKURA SKY and SAKURA STAR trials of satralizumab. And as a reminder, the difference between those two was in the SAKURA SKY trial, individuals could be on background immunotherapy, whereas with the SAKURA STAR study, it was a monotherapy trial. And these were placebo-controlled trials. These are the trials that led to regulatory approval, whether it was the FDA or EMA or anywhere around the world, for any or all of these drugs relative to aquaporin 4 antibody-positive neuromyelitis optica. So what did the trials do relative to primary outcomes for determining the efficacy of these drugs? all of these trials used relapses as the primary outcome. And if you look at the language within each of the protocols for the PREVENT or CHAMPION trial, the N-Momentum trial, or both the SAKURA SKY and SAKURA STAR studies, you can find language on how that primary outcome, specifically a relapse, would be adjudicated. The PREVENT and CHAMPION trial was powered around time to first adjudicated relapse, as was the N-Momentum trial. The SAKURA SKY and SAKURA STAR study had a slightly different language, time to first protocol-defined relapse. But in the end, each of these trials were similar in many respects, but distinct in many respects into how they adjudicated whether or not a clinical event was indeed a relapse. So let's talk about each of these in turn, and let's start with the eculizumab and ravulizumab trials. So these were the PREVENT and CHAMPION studies, and as a reminder, the PREVENT study looking at eculizumab was a placebo-controlled trial enrolling individuals with seropositive anti-aquaporin 4 antibody neuromyelitis optica. And the ravulizumab study, the CHAMPION NMO trial, used the placebo arm from PREVENT as a historical comparator because the enrollment criteria were similar and indeed the primary endpoint was the same. What was the definition used in the PREVENT and CHAMPION NMO trial to define a clinical event as a relapse? Here's the language. If you had looked through the protocols, you would have found for dictating whether or not a clinical event was a relapse. An individual needed to have new or worsening neurologic symptoms. This was new onset or worsening of existing signs or symptoms. There had to be an objective examination change. So whether or not you were looking at visual acuity or somebody's strength, or their walking, or their sensory exam, there had to be something on examination that changed. So a subjective report of a symptom would not have been characterized as a relapse. There was a minimum duration. The symptom had to persist for at least 24 hours. Symptoms that came and went in under the 24-hour period would not meet the definition. The symptom or sign that was being found had to be consistent with an attack of NMO, and there had to be no other identifiable causes, such as infections or other systemic illnesses. And importantly, the individual had to have prior stability. So in the previous 30 days, there could not have been new events. And this was important for separating out a stuttering relapse event versus something that was truly new and should be counted as a single relapse. So if an individual met all these definitions, their data was reviewed, and this gets to the notion of adjudication. And this is where there were distinct differences between the trials. Let's look at the PREVENT study's adjudication process. So adjudication of trial relapses was based on a consensus of independent relapse adjudication committee members. There were 2 neurologists and 1 neuro-ophthalmologist in order to ensure a diverse level of expertise around looking at data from an optic neuritis versus myelitis perspective. A distinct feature of the PREVENT's relapse definition, which was not present in the SAKURA trials or the N-Momentum trials, was a formal severity grading system applied to every confirmed relapse. The relapses were using a worse severity observed over all the visits, using something called the optic spinal impairment scale, where relapses were characterized as major or minor. Importantly, there has been one widely noted limitation of the PREVENT relapse definition, and that was the fact that the formal adjudication criteria were not in place at the trial's outset. So the trial launched and individual relapses were being judged at the individual sites, but ultimately the decision was made that there needed to be that centralized review of the data, that adjudication panel that had the 2 neurologists and the neuro-ophthalmologist. So the adjudication system using the EDSS and the optical spinal impairment scale were launched mid-course during the study. So after 88 participants had already been enrolled. So the earliest enrolled patients were assessed under a different standard, and this has been acknowledged as a limitation that prohibits us or prevents us from doing cross-trial comparisons. The PREVENT trial also ran 2 parallel relapse endpoints simultaneously. There were physician-determined relapses, meaning non-adjudicated, which was the original primary endpoint. This actually occurred in 14 patients on eculizumab and 29 on placebo. So there was a statistically significant difference between those two arms, but the rate of relapses in the patients on eculizumab was significantly higher using this endpoint versus the ultimate primary endpoint, which was the adjudicated relapses. So this accounts for the discrepancy between the two rates. There was only 83% of patients who were relapse-free based on non-adjudicated relapse definition, whereas the most highly cited relapse-free rate of 96% references the adjudicated relapse process. This highlights a standard issue when we come to relapse definitions and adjudication processes. Individuals in the trenches seeing patients on a day-to-day basis have a very different view, maybe better, maybe worse, than a centralized adjudication committee. And well-meaning clinicians and experts in the field might not always agree on the interpretation of data that's being reviewed. Hence, we come to this fundamental issue within the practice of neurology and neuroimmunology, and a recognition that the endpoint matters and the process for determining the endpoint matters significantly as well. How does this experience with eculizumab and ravulizumab compare to the other drugs that we now have approval for? Let's turn our attention to satralizumab. And as a reminder, this was studied in two independent trials, the Sakura Sky and Sakura Star studies, looking at satralizumab versus placebo, either as a monotherapy or as an add-on to background immunotherapy. So what were the relapse definitions used in each of these trials, Sakura Sky and Sakura Star? So the primary outcome was protocol-defined relapse confirmed by a clinical event committee, essentially the same type of team as an adjudication committee that we saw launched partway through the PREVENT trial. A protocol-defined relapse was any new or worsening neurologic symptom attributable to NMO that persisted for a minimum of 24 hours and was not attributable to some other confounding clinical factor. This is essentially identical language to what we see in the PREVENT trial for eculizumab. Symptoms that recurred within 31 days were considered part of the same relapse. Again, a reminder of this separation of about a month between events in order for the second event to be called a relapse. The relapse event had to meet one of the following criteria, and this was based on increases in scores on the EDSS, either a 1-point increase or a 2-point increase if the EDSS baseline was 0. And as you can read, there were different levels of point increases depending on what functional system was affected and what an individual's baseline was. So this was very objective data based on disability scales that would put somebody in the category of relapse versus not. The most recent EDSS and functional system scores were used as the basis of comparison. So if an individual had had a little bit of change in their EDSS in the month preceding, but it didn't qualify as a relapse, but in the next month, they went up even further, that most recent score would be the one that was compared to not the baseline score. The functional system scales included the classic parameter, cerebellar, brainstem, sensory, bowel bladder scores, and visual scores. Importantly, sexual dysfunction and cerebral function was not used to establish a protocol-defined relapse. And to be included in the primary analysis, relapses had to be assessed within 7 days of the patient reporting symptoms to the study site. Because the protocol definition required this objective change on the functional system scale as part of the EDSS, the individuals had to come in and be assessed in order to ensure the relapse definition was met. This requirement led to some missing data. Patients who could not make it into a site within the 7 days of patient-reported symptoms could not be included in the primary analysis. In both studies, the blinded clinical event committee consisted of 3 neurologists and/or ophthalmologists who had expertise in the treatment and management of NMO and were well-trained in these various functional system scales. The treating investigators managed the patient care and monitored safety. So there was an important separation at not just the evaluation level, but at the site level between blinded assessors and treating neurologists in order to create the most rigorous data set for that clinical event committee to review. Interestingly, a sensitivity analysis was completed by the sponsors of the Sakura Sky and Sakura Star studies to determine if alternate definitions of a relapse alter the primary endpoint. So again, to remind you about the PREVENT trial, if you use the clinician-derived measure of an event, there were more events identified than what was ultimately adjudicated. So this sensitivity analysis was a formal way for the satralizumab sponsors to get at the same issue and ask the question of, are there differences between those who are seeing patients at a site versus the adjudication committee? So if we look at data using the protocol-defined relapse, so these are individual relapses that met the clinical event criteria, the clinical event committee criteria as a relapse. This is a busy slide, but let me walk you through the important part. If you look to the right-hand side of the slide, you'll see on the table that the population was limited to an aquaporin-4 IgG positive subgroup. This is ultimately the group that got regulatory approval. The original trial included individuals who were both seropositive and seronegative. Ultimately, the drug was found to work for those who were seropositive, thus the label. If you look at the data of number of patients who had a relapse either in the Sakura Sky or Sakura Star study, you find 12 and 3 in terms of placebo versus satralizumab in one study, or 13 versus 9 in another. And this is the protocol-defined relapse. If we compare this to individuals who were designated as having a relapse clinically at the site, the numbers change. So let's look at that top line, 12 placebo patients, 3 satralizumab patients having a relapse in one of the Sakura studies, and compare it to 17 versus 11. So instead of there being 3 seropositive NMO patients being deemed of having a relapse, in the clinically defined group, that number goes up to 11. So again, similar to the PREVENT trial, a rigorous definition around a committee looking at the data leads to a lower relapse rate than what gets called in the context of a clinical care scenario. Does this represent a fundamental problem with what happens in the clinic? I would answer no. It represents a fact that in clinical trials, once someone is deemed as having a relapse, they can move out of the trial and into an open label extension, or they can be triggered to receive steroid therapy. And if you're a clinician responsible for a patient, your threshold for calling a relapse might be lower than what would be used in a central committee identifying relapses for the purposes of a clinical trial. So the perspective of the assessor matters, and their goals relative to the situation shade their view relative to the data being interpreted. So let's turn to the last of the registrational trials relative to neuromyelitis optica, specifically the study looking at inebilizumab in individuals with neuromyelitis optica. So the NMOMentum clinical trial relapse assessment protocol was probably the most rigorous of all the trials. So patients who had new or worsening symptoms possibly related to NMO were assessed by the investigators within 72 hours of symptom onset. If the investigator felt that those symptoms were NMO related, there was a continuation of the assessment. They had their EDSS and functional system scores done, they had an ophthalmology exam, and importantly, they had an MRI. This was the one study to require MRI as part of this assessment. The assessment was reviewed by the investigator using a protocol-defined attack criteria as either attack or no attack, and ultimately the attacks were adjudicated by an adjudication committee within 17 days of the start of the assessment. And it was based on the adjudication committee's assessment that a participant could either move into the open label portion of the trial or continue in the randomized control portion of the trial. There were 43 adjudication committee adjudicated attacks, and they used a large list of clinical and MRI criteria to define whether or not something was an attack. Within each of the functional systems, for example, within vision, the criteria stated how much of a visual change had to occur for something to be considered an attack. And if a threshold was not met clinically, then MRI data had to be included in order for the committee to determine if something was or was not an attack. What was the impact of this very rigorous adjudication process relative to the NMOMentum trial? So importantly, if you look at the committee, votes were cast relative to each of these reviewed events. And you can look at the percent of individuals who were unanimously voted as having an attack or not an attack, and then the individuals where it was a majority vote. And I just want to point out that you had a group of specialists on the adjudication committee, trained in NMO, experienced in NMO, and in 1 out of 5 cases, there was not a consensus opinion. The only reason I stress this is so that we all accept the fact that multiple clinicians and scientists looking at the same data can come to different conclusions, even with rigorous relapse criteria. This is not to say that there's a flaw in the system, it's just to note the inherent difficulty in using clinical scales in the context of neuromyelitis optica and determining with certainty whether or not somebody has experienced an attack or not. And if you look at the separation between the adjudication committee and the protocol-defined relapse from the context of the clinician at the clinical trial site, overall, there was a majority of agreement, but there were a few disagreements, and those really fell into the categorization of some that were deemed not an attack, determined in the original adjudication. What about the relevance of MRI to determining whether or not something was an attack? So if you looked at individuals who had GAD-enhancing lesions as part of their assessment, you could look at the fact that in myelitis, the MRI was relevant in the adjudicated attacks in 90% of the time and 95% of the optic neuritis attacks. And so overwhelmingly, individuals who were adjudicated as having an attack had substantiated evidence within MRIs to prove that it was an attack. Interesting to the NMO trial was the investigation of biomarkers relative to relapse adjudication, specifically GFAP levels in the serum. The steering committee for the N-Momentum trial did an interesting analysis looking at the intersection of MRI data such as this, GFAP levels, and clinical criteria for determining relapses. And what they found was an overlap for the 43 adjudication committee adjudicated attacks, that if you were to look at all 43, which is represented here by the large circle, there were 14 individuals who had lesions only, 17 who had both MRI lesions and elevations of serum GFAP. There was 1 individual who had elevated serum GFAP but not a change on the MRI, and 2 individuals who did not have an obvious lesion or elevation of GFAP. So it shows us that while these clinical criteria are quite good, MRIs and biomarkers may play a substantial role in helping to confirm relapses. And in a minority of patients, 2 out of these 43s, the adjudication committee felt strongly that the clinical event was indeed a clinical relapse despite imaging and a blood-based biomarker not confirming it. This tells us that the clinical practice still matters, that there is not a technological fix to determining with 100% certainty whether or not someone has had a relapse. And that brings us nicely, I think, to the other side of adjudicating relapses, specifically what happens in the clinic. When we talk about clinical care, which has very different goals from clinical trials, we are trying to determine whether or not the patient in front of us is having a new attack of neuromyelitis optica. And the impact of this decision is significant. First, if somebody is having a relapse event, we will take them down the path of acute therapy. This may include steroids or plasma exchange. While steroids are overwhelmingly safe and we use them all the time, there are rare risks to using high-dose corticosteroids, and there are rare risks to doing plasmapheresis. The misclassification of a clinical event as an acute relapse could lead to unnecessary and potentially dangerous, even though that danger is small, potentially dangerous interventions that would be used inappropriately. So in the short term, determining with accuracy whether or not one of our patients has had a clinical relapse is critically important. Long term, however, if we decide that somebody has had a new event on background therapy, we may change their therapy. This could change the risk profile. They may go from a safer drug to a riskier drug. They may go from a drug that was working to one that isn't. So if we inappropriately call something a relapse, we can subject individuals to unnecessary therapies and change therapies inappropriately. So what do we do to evaluate patients in clinic relative to the question of relapse? So there was a nice survey that was published in 2020 in multiple sclerosis and related disorders that surveyed people from around the world. The majority of individuals were either in Germany, the US, or France. Most of the participants worked in university hospitals, academic centers, tertiary centers, but about a fifth were in other hospitals. And the vast majority of the participants in this survey study specialized in neurology. And when asked a series of questions, the answers are quite interesting in the current approach to relapse workups. So individuals were asked the question, do you always, regularly, or rarely, or never perform tests when an individual comes in with myelitis as a suspected first attack of NMO? So what do you do when that patient comes in with a myelopathy and you say it's myelitis? What are the tests you do? Almost everybody got brain MRIs, spinal MRIs with gadolinium. There was some sort of fundoscopic exam, either with technology or a good old-fashioned ophthalmoscope. The optic nerve could be interrogated by visual evoked potentials or functional tests with high contrast or low contrast visual exams. Everybody did neurologic exams. And ultimately, the overwhelming majority of individuals did AQP4 testing in all patients with a first myelitis attack. What about a person presenting with optic neuritis? What you'll see is a very similar pattern. So again, this is a patient coming in with a new onset optic neuritis, people getting both ophthalmologic and neuroaccess imaging, and overwhelmingly getting that antibody titer. But let's move from a first attack to what the answers were relative to relapses. And this is where it gets interesting. So what do you do if you have an NMO patient coming in with a possible myelitis event? There were still some individuals who were getting brain MRIs, although we saw rarely pop up there. The majority of folks were always getting a spine MRI, but it wasn't everybody all the time. Some people rated it as regularly or rarely. Some people would repeat imaging of the visual access. Neurologic exams were made the foundation of the assessment. And what was interesting was serial exams of the AQP4 antibody, retesting of the AQP4 antibody, with most people saying rarely or never to repeating the testing in an established patient. So MRI for a myelitis patient seemed to be overwhelmingly the evaluation that folks were doing, with a lot of folks following the NMOmentum trial, which would get imaging with every suspected relapse in order to confirm it. Similarly, in the setting of optic neuritis, we see individuals getting imaging, but we see an increase in the amount of OCT or ophthalmologic testing happening. But of interest here, I would note that the MRI with gadolinium shifts a little bit from always to regularly. There was less of a use of MRI to confirm optic neuritis and maybe a reliance on other technologies to confirm a diagnosis in clinic. So what do we do to assess for a potential relapse in the clinic? I'll tell you my approach, and then I look forward to answering questions about this topic of adjudicating relapses. So we have a patient calling in with symptoms, and those symptoms might be felt to be myelitis or optic neuritis. We really have a first branch point on whether or not those symptoms are occurring in an area that has never been affected by NMO versus previous effects. So if this is truly a new symptom, for example, your NMO patient who had only had myelitis in the past, calling in with new vision complaints. So their optic nerve had never been affected before. In that situation, based on what I call pre-test probability, we decide if we're going to empirically treat versus getting imaging. What is that pre-test probability? Well, if somebody calls in and they have mild blurred vision with no pain, the pretest probability of being optic neuritis is lower than an individual who calls with pain behind the eye, worsened with eye movement, and a significant graying or blurring of their vision. In the former case, I might get imaging first while arranging for treatment to be ready, because there are so many other potential explanations for mild blurred vision other than an NMO attack. But in the second case, an individual who's never had optic neuritis before, calling in with pain, calling in with blurred vision, we're likely going to start treatment immediately, even if we're going to work to get confirmation imaging in parallel. This is different than an individual calling in with an exacerbation of prior symptoms. I'll give you an example. An individual who had had prior myelitis leading to left leg weakness. They recovered and their walking got back to normal, but they call with a recurrence of left leg weakness. Again, based on pretest probability, we discuss testing versus imaging versus treating. What do I mean by testing? It's looking for other features clinically that may exacerbate old symptoms, like urinary tract infections, fevers, coughs, colds. In an individual whose symptoms are of moderate or mild severity and they've had them before, we might get imaging before we go down the path of treatment. Particularly important to this group is recognizing the need to be certain that somebody is having a new NMO attack before committing them to acute therapy and or changing their background therapy. So this is just a practical guide we use. Every case is different, every situation is different, but it's one way to think about things when assessing the potential for relapses in our own clinical practice. So I hope you have found this helpful, both the how and why do we adjudicate relapses and the implications of different definitions, both to our clinical trial data as well as to our clinical practice. I appreciate being invited to take part in this masterclass. Hope you found it interesting. I look forward to answering your questions.
Dr. Greenberg, thank you so much for that excellent presentation regarding adjudicating relapses. Why and how? There are a few questions, Ben. If you don't mind, we can go through these and get your insights as regards some of the important points regarding relapse. First, maybe you could just explain how a patient can have a change or increase in symptoms in the absence of a relapse.
Yeah, Michael, it's a great question. As we talked about during the master class, not every new symptom turns out to be a confirmed relapse. And so the natural question that comes up both in research and in the clinic is, how can this be the case? We get calls from patients all the time with either a return of eye pain or blurred vision or weakness or numbness. And the concern is obviously for new inflammation first and foremost. But at times people can be having what was sometimes called a pseudo-exacerbation. And there was a old term, UTOS phenomenon, where individuals could have a return of symptoms due to a prior attack without new inflammation. The theory behind it is that once the connection between parts of the nervous system is interrupted, once demyelination has occurred, but there's still an axon that's present and functioning, the brain compensates to get signals through. The nervous system compensates to get signals through. But under times of systemic physiologic stress, that compensation goes offline. And so in neurophysiology terms, you can have a conduction block, where if we're talking about the optic nerve, the signal does not make it through as well, and somebody has a return of their blurred vision. This can happen for a lot of reasons. We've seen it most classically in the setting of increased body temperature, but this can happen under any stressor. We are one of the most frequent orderers of urinalysis in the hospital because when patients come in with symptoms, they can have asymptomatic urinary tract infections. And while their body is fighting the infection, even if they don't have a frank fever, that systemic stress can bring out old symptoms. I've had one patient who every time they had an argument with their significant other would lose vision in one eye. That physiologic stress, that emotional stress that affects our blood pressure and our pulse can cause a change in function. So anything that causes compensation to go offline can lead to a transient worsening of symptoms. So we cast a broad net looking for those other explanations in order to both rule out or rule in if a new event has occurred.
Thanks a lot, Ben. Very helpful insights. And obviously, we have a lot to learn about the physiologic underpinnings of relapse, but that is very helpful. The next question, Ben, is related to sort of defining a relapse. In each of the NMOSD clinical trials to date, there was a different definition of relapse, which kind of just leads to the question, why is developing a standard definition of relapse important?
Michael, it's a great question. I think we saw that in the data we reviewed from the different NMO trials, where as investigators at the sites would raise the question of a relapse, a centralized adjudication process was undertaken with different definitions, different criteria, and frankly, different data in order to ultimately decide was somebody having a relapse or not. And the missing piece amongst all these trials was a standard universal definition of a relapse. And this is going to be critically important for us moving forward with clinical trials so that we have more comparable data sets as we go from trial to trial, because without a standardized definition, it's actually very difficult to compare evidence between trials if we can't even agree on what signifies the minimum data required to call something a relapse. What's important, though, around this notion of a standard definition is we always talk about it in the context of clinical research trials to try and get that comparable data set. But I actually think we also need a standard definition in the clinic, because while clinical trial data is critically important for us making prospective decisions about what therapies work or don't work, we need data in the clinic to decide if somebody's failing a therapy. If somebody comes in with new symptoms and we decide it's a relapse, that has profound implications for the patient in terms of looking them in the eye and saying, I think you're having breakthrough disease. Should we consider one of the multiple options that we have relative to therapeutic interventions? And it becomes a question of what is the minimum level of data that would be required to make such a clinical recommendation. And that's hard. We struggle with this all the time. If somebody has mild symptoms and we don't get an MRI and we're questioning, was it or was it not a relapse? For trials, it makes a difference. For drug approvals. For the patient, it makes a difference on, are they on adequate therapy or not? So coming up with a standardized definition or a tool, something that can reliably tell us as much as possible if somebody's having new acute inflammation, it'll go a long way to helping us both on the research side and on the clinical side.
Yeah, agreed, Ben. And thank you so much for being part of a panel that's been working on this kind of a tool for some time now. But as you say, if you have different definitions, one patient on a given drug might be deemed to not have a relapse, but on the same drug could be considered, to have a relapse by someone else. So very, very clear and important. And along those lines, Ben, what are the kinds of features that you think about clinically that support an event as being a bona fide relapse as compared to a pseudo relapse?
In my younger days, I used to think that there'd be a single answer to this question, that there was a minimum threshold of clinical change and that would always be a relapse, or an MRI finding would always be a relapse. And one of the things I've had the privilege of over these last now 20, 25 years is to work with thousands of patients in different situations to learn that each patient is a little bit different and there isn't always a singular threshold that can apply to every situation. And so on the clinical features, I break them down into two categories. One is looking for evidence of a relapse in an anatomic distribution that has had prior symptomatology. So somebody with a previous right eye optic neuritis is coming in with right eye symptoms, versus the clinical features that are required to call a relapse in a distribution that has never been obviously affected before. And the thresholds are different because of that UTOFs phenomenon that I mentioned earlier, because of the possibility of a pseudo exacerbation. And so if we're dealing with a environment where the anatomy hasn't been affected before, the threshold for calling a relapse is lower. So if somebody has had 20/20 vision in their left eye for their entire life and now goes to 2200 with pain on eye movement, I don't need an MRI to confirm that that's optic neuritis. If they have the classic features in response to therapy, we'll call that a relapse even without additional data, which is different than new pain and vision loss in an eye that was previously affected. And so depending on what the patient's prior history was, there are going to be different clinical features. In general, A relapse will have symptoms for 24 hours or more. It is highly unusual to have symptoms that come on and resolve in under 24 hours. So in general, it should be longer than 24 hours. In general, those symptoms should not have another obvious explanation. And then you take into account whether or not the anatomy was previously affected, and you can get to a reasonable clinical approach to determining if something was or was not a relapse.
And as you say, Ben, a lot of that's dependent on sort of relative change from baseline, right?
It is, and the total clinical context. I'll give you an example. I've had patients come in who had a baseline of 20/40 vision, 20/60 vision because of a prior optic neuritis, and they were doing well, but they were coming in with recurrent eye pain and transient blurred vision. And a lot of times from clinicians, they were being treated with steroids for possible optic neuritis, more than over and over and over again, only to find out that they had severe dry eye and corneal changes, and the eye pain and the blurred vision was from their dry eye and on top of a prior optic neuritis. And these recurrent steroids or change in their underlying disease modifying therapy were happening for the wrong indication. And so we can be fooled with individuals having multiple explanations, and anyone who's had prior damage, it doesn't take that much of another pathology for it to become symptomatic. And so for somebody who has spinal cord issues, it doesn't take much of an orthopedic, a musculoskeletal issue to bring out symptoms of dragging a leg or pain in a leg or weakness. And it's not new spinal cord inflammation, but it's the combination of two things.
Ben, let me just follow up for a moment on that, because the case you just described illustrates potential comorbidities. For example, what about Sjogren's on top of NMOSD, for example?
Yeah, it's a great point. As you're well aware, we'll see evidence of other autoimmune conditions if we use that term very broadly and we just say serologically, if we're looking for other autoantibodies in anywhere from 20 to 30% of our NMO patients. And if we're looking for individuals with even mild symptomatic expression of those disorders, it's a significant number of that fifth to a third of our patients. And at the top of that list for NMO is Sjogren's or systemic lupus. And so one of the classic phenomenologies I've seen, at least, is when patients have both, often the lupus or the Sjogren's has relatively mild manifestations, and it isn't as clinically obvious as somebody showing up to rheumatology with classic Sjogren's. And so we'll hear about sicca symptoms, we'll hear about dry eyes and dry mouth, but we're so focused on NMO as the diagnosis, we tend to have blinders to the other things that can happen to our patients. I've had individuals with blurred vision being treated with steroids over and over again, only to find out that it was cataracts. And we were accelerating the cataract with repeated steroid exposure. And so it's important when thinking about diagnostic criteria or relapse criteria, whatever criteria is published, there's always an asterisk at the end of the list, whether it's 3 criteria or 10 criteria or 15 criteria. The last criteria is always ruling out other explanations. And this is often the one that gets missed the most when there are cognitive errors, whether it's on relapse adjudication or on diagnosis. And it's always taking a step back and just asking ourselves the question, is there anything else that would reasonably explain this that we should be investigating?
Excellent insights, Ben. Thank you very much. You mentioned MRI and the need sometimes for more objective, sort of quantitative data, if you will. Can you talk a little bit about when MRI is needed to confirm a relapse and why that is important?
So as we look at the data in the world of NMO and other conditions, the MRI can be quite helpful, but has to be interpreted carefully when being used to confirm new inflammatory activity. And so an MRI, in my opinion, is absolutely needed if we are unsure, based on the clinical criteria, whether or not something rises to the level of a relapse. And so maybe there is a potential alternate explanation, or maybe the symptoms are mild, or maybe the symptoms are in an area that was previously affected and it's not clear if there was a secondary explanation. In any of those gray areas, the MRI becomes critically important with a couple caveats. The first is MRIs are not perfect, and MRIs can both be over-interpreted and under-interpreted. I've seen patients who were diagnosed as optic neuritis where the enhancement on the optic nerve was a blood vessel and not actual enhancement of the optic nerve. And so it is not a perfect test, but it can be critically important to help us decide if something is or is not a relapse. And the reason that that process is important, and the reason it's important to have such a high standard before you dictate something was or was not a relapse, is it has profound implications for patient care, particularly for individuals who are already on immunotherapy. If I have somebody who is on, pick any of the FDA-approved drugs, and you have a patient on it and they have a relapse, there's going to be a conversation on should we switch the therapy. And it's a binary categorization. You've either had a relapse or you haven't. And if you had, it triggers that conversation about switching a therapy. So if we're on the fence clinically, getting the MRI to confirm can be quite important before just switching immunotherapies over and over and over again. And I should note, just because somebody has a relapse on an immunotherapy does not mean they have to switch therapy. The context is important. If they're within the first couple weeks of starting the therapy, we may not call that a failure of the drug therapy. It's a failure for it to kick in as quickly as we want. But that information is important. We want to know whether or not somebody is having events. And, I love looking at clinical trial data and I having plots where there are little diamonds for every patient relapse, and it looks so neat and tidy and quaint, and we take it as fact that the diamond is there, they had a relapse. And then when you're in the clinical trial, in the trenches or on the adjudication committee, and we're all looking at each other going, I think we should put a diamond there, but I'm not sure, that MRI can become quite helpful for, in retrospect, going back and deciding, all right, it was or was not an actual relapse.
Yeah, thanks a lot, Ben. Real world, not always as clean as we'd like, right? Lastly, Ben, maybe you could just comment on the opposite of everything we've just been talking about, which is it possible for a patient to have a real relapse, a new inflammatory event, but in the absence of symptoms that you might normally look for?
Yeah, that's a great question, and it's actually been a controversial one. So we talked about some of the MRI data that came out of the trials that suggested there might be some inflammatory events without clinical correlations in neuromyelitis optica. As a baseline, I think the frequency of that is very low or rare, particularly compared to other inflammatory disorders of the central nervous system, the obvious one being multiple sclerosis, where we know that there can be a number of events that happen asymptomatically. I think that rate is on the low side with neuromyelitis optica. It's never going to be zero. But it still, at least in our practice, has not risen to the level to trigger us to do asymptomatic serial annual MRIs of all our patients. Have we done episodic MRIs to take a look spaced out over years? Yes, for a variety of reasons, but not in a systematic surveillance perspective. I have used optical coherence tomography because it's so accessible, it's so easy, it's so cheap. You don't have to dilate the eyes, and you can really get a sense of whether or not there are optic nerve changes. And it's one of the data sets that's reassured me. The number of times we have seen in an adult population an NMO patient have an asymptomatic change in their retinal nerve fiber layer, the thickness of that optic nerve, has been exceedingly rare. And so I feel comfortable following patients clinically as long as they're engaged in their care, they're reliably reporting symptoms. I've had situations where we do MRIs because I'm not sure if we're getting the full story based on individuals, but for the most part, I think those events are rare.
Ben, thank you so much. It's been a pleasure to learn from you today. I'm hopeful that this will be very helpful to everybody who watches this. And with that, we want to thank again Dr. Benjamin Greenberg, University of Texas Southwestern. Ben, thank you so much.
Appreciate it, Michael, and thank you to the Patient Health Alliance. I hope this is helpful to everyone and look forward to doing more in the future.
The Patient Health Alliance is excited to provide the masterclass for your consideration. You can find additional information about the masterclass, as well as featured speakers, educational events, and other presentations and media at the Patient Health Alliance website, which you can access using this QR code. And lastly, the Patient Health Alliance is grateful to Alexion for its support of the NMOSD Master Class and its educational mission. With that, thank you so much for your attention.